Hey, it's cold out.
It is cold. Well, it's not so cold as it's a little wet, and that makes it really cold. And I'm old. My hands are cold. I'm wearing my jacket. Ray,
So, wait a minute. This is Ask the Doc with Dr. William Whaley and Ray Tidman. We're going to take the first 3 or 4 minutes to talk about what hurts.
Okay, now wait a minute. No.
My shoulder. What's with you? My shoulder and elbow hurts. And you?
We usually talk about the tie, but we're
We're
not talking
going there
about
in
the
a
tie.
minute.
No,
The
we're
fish.
not. We're talking about, well, that's my Christian tie.
Right.
We're talking about the memo on the shirt collar.
Yeah.
Okay, I've got a button-down blue shirt. These come from Joseph Bank, and I think they cost 6 for $100 or $28 or something. Ray's shirt cost more than the first 2 cars I owned.
This was a gift from Earl Klug's family to me for my birthday last year, and I haven't worn it yet, and it's handmade.
Yeah.
And it's feel that fabric.
And it came from
Who knows?
markup,
Yeah.
and you're sure your wife didn't buy it and pass it on?
No, this is a handmade shirt
I know
in Marietta.
Okay, but anyway, point I'm making is he's always got socks that cost more than my jacket on. So, but anyhow, and he just got back from being on his yacht for 10 days.
Yeah.
He is. Is this Ask the Doc, or are we roasting Ray?
Roast Ray.
If you would have told me before he came in, can I get in on this?
I need the violin because I had to get on an airplane, and that sucks right now. So
You know what you just did? Did you just make a Jack Benny reference
Yes.
to the violin, right?
yeah.
And we're wondering out there who knows.
They
Jack
don't
Benny.
know that.
Okay,
Yeah.
so-
Well, our audience might.
All right, well, go ahead, Rochester.
Manchester. All right, listen, we're here at the sponsorship of the Georgia Cancer Specialist with the Northside Hospital Cancer Institute. We're here to talk about questions that have been sent in, and 2 of these questions are quite interesting in that common things are common. What do they say in medicine about the
When you hear hoofbeats,
hoofbeats?
don't think zebras.
What does that mean?
Yeah, it's probably horses.
Okay, probably horses. All right, well, that's here are 2 common conditions, both of which are uncommon in their presentation and in their length. My mother is 82 years old. I'm 82 years old, and on blood pressure medicines, and has a failed surgical back problem on chronic pain medications, but otherwise is in great shape. That's a real good description, because Ray and I have patients that you would look at and they look like they're 60 years old, but they're 80 and they're on blood pressure medicines, and they let somebody operate on their back 10 years ago or 20 years ago and they hurt all the time, and they take pain medicines, but you'd never know it, right? I mean, so when he says she's in great shape, I understand what he's saying. All right. Now, she lost 40 pounds in 6 months. That's not great shape now, is it, Ray?
No.
She has lymph nodes that are tender everywhere and is anemic, so she's not in great shape now, is she? The oncologist diagnosed grade 1 to 2 follicular lymphoma, and only 2% of the cells in her blood are lymphoma. She has a large mass in the lung, a small mass in the bladder. Lymph nodes in the neck are very small but tender. Now, the guy's talking about what we've said here before, and I think he's right, and that's why we're going to spend some time on this. You recommended observation for a patient with follicular lymphoma a few months ago, and now the oncologist recommends treatment soon, and he capitalized soon, with Rituxan and some sort of Benda drug. Why not observe, and if treated, why not the CHOP like BKP's mom got? Well, you got that figured out?
No, I don't have it figured out.
Well, you understand you understand the question. Question is that we have frequently talked about chronic lymphocytic leukemia. Observe, they're not sick, just have an abnormal clone in their blood, and follicular lymphoma, we've said, is the lymph node equivalent of chronic lymphocytic leukemia, and it's best observed and not treated, right? Said that right to you. All right, put up that first one. So we're going to talk about follicular lymphoma. So you got the title slide. Pick up the next one. This patient, if you look at this diagram, this patient we know has involvement of the bone marrow because the cells are in the blood, even though there's only 2%. We know that they have involvement of non-lymph nodal tissue because they said there's a mass in the lung and there's a mass in the bladder. Pull that down. Now, we don't know that they biopsied all of those, but, common things are common, and it's very unlikely she'd have lung cancer, bladder cancer, and lymphoma all coming on in less than 6 months, right, Ray?
Yeah.
Okay, go to the next one. Most of the time, you got the next one? That patient laying on his side there, most of the time when we talk about follicular lymphoma and chronic lymphocytic leukemia, the patient has been to their PCP, they did a blood count, and they got abnormal lymph cells in it, and they're not sick. Or they got a bump in their neck, they went to their PCP, they worked it up, and it's a follicular lymphoma. They're not sick. So this warning signs of lymphoma, I'm not going to go in, but they're everywhere. You could swelling of the ankles and shortness of breath and blah, blah, blah. Pull that down. When a patient comes to Ray, and his feet and ankles are swollen and his hemoglobin's 6, and he works them up and he finds follicular lymphoma, it is not the same disease as the patient with the bump in the neck who's not the least bit sick, right?
Correct.
Okay, so now we talk about follicular lymphoma. This lady's got every one of them. Weight loss, that's over 20% of body weight. Significant fatigue and enlargement and tenderness of the lymph nodes. Pull that down. So when we talk about stage, this is advanced disease. Got the next one up there? So she's got it on both sides of the diaphragm. It's in other organs. Pull that down. I'm going to leave this conversation for a minute. You have heard me say many, many, many times here, and I've gone back and described a patient that I still see now that I first saw 45 years ago. And there's a second one I see now that I first saw 35 years ago. The preacher had fungal sinus infections. Dr. Don Dennis diagnosed him long ago, repeatedly had biopsies of his mucosa and nodes in his neck, and it was always reactive lymphocytosis, not malignant. After 20 years of that, he had a B-cell lymphoma. It's been treated. He's been in remission on and been continually treated, really off and on for about 15 years. The second one was a woman with rheumatoid arthritis, and she was repeatedly getting lymph nodes in the neck. She had biopsies, Mayo Clinic, the Armed Forces Institute of Pathology, all the top pathology people looked at least 15 lymph nodal biopsies or aspirations from her lymph nodes over 25 years before she showed up with follicular lymphoma. So what that says is that if you have a chronic inflammatory process somewhere, it is not likely, but it is possible that repeated antigenic stimulation of the lymph node to make antibodies and get big can sooner or later become malignant. Ta-da! Now, you want to see
Let
something?
me interject a little
Please.
primary care point here. So, if you have a lymph node or a lima bean under your skin, in lay terms, it's a very common thing. Almost anybody at any time was probably going to have a swollen lymph node from a scratch or an injury or something where the body's reacting and fighting off that
Or a
little
zit.
thing.
That's what I was waiting to hear, but that generally is where the body's reacting.
The immune system
Right.
kicking in and
Yes.
enlarges that lymph node to
Right.
fight that off. So those
Right.
they're very, very common. So what I tell folks to do if they come in and they say, well, I've got this lima bean under my neck here, and we feel it, and we measure it, and make a note of it.
And
Is-
do a blood count.
we do their blood work and all the rest of their exam. But the point being is that the instructions are, you watch that, we'll recheck it in 3 months, or if it's getting bigger or more tender, come back in quicker. But if you start losing weight, or you have other systemic changes like marked fatigue and the things that this lady's
fever.
complaining of, then you're going to get a thorough cancer workup right away. Weight loss with persistent adenopathy is, in my book, cancer till proven
Sure it
otherwise.
is, yeah.
So,
Well, I will say,
Yeah.
he called it the lima bean.
yeah.
We up here in the country, and all of us are, none of us are carpenters, okay? And all of us have gone out and tried to drive a nail where a nail comes out and whacked ourselves in the thumb with our hammer, and then we get a black fingernail, and then we get a painful knot under the elbow and a painful knot under the arm. And when we were kids, Mama called them kernels, and now when we're adults, they call them lymph nodes. But anyway, they're so common up here in the country where people are working all the time. I mean, many of the carpenters and the farmers have
Yeah.
got lymph nodes all the time. in
And that's
response
why I'm
to
making this
something
point.
somewhere.
Right. I don't want people to say, oh, I've got a lump, I need to go to the doctor.
Yeah, so it's a normal thing. Okay,
Yeah.
put this next one up, because it'll help you a little bit. These are beautiful blue pictures. This lymph node on the left-hand side is a regular, normal lymph node of somebody who's got a really bad hunk on their finger or a boil on their arm, and that's the lymph node that's draining it, as Ray says. And once you open the boil up, or the thumb gets better, or the zit on your cheek gets better, that lymph node's going to go away. Well, this is a follicular lymphoma right beside it, and these little circles on the normal side are what these women, what that sinus preacher and that woman had for decades, that sooner or later did that. Okay, pull that down. So, now I'm not going to try and bore you, but just so you know, there's a lot of science in this. This is sort of a cartoon of what happens to the normal lymph node, which is right here at the top, when it begins to get immune stimulation on the right and becomes his kernel. He calls it a lima bean. I usually call it a grape, but you get it. And then over time, if you continually get it, then this time sequence in these two patients were both 20 years or longer. Pull that down. So we don't know that this patient got this from some chronic inflammation, but I am using those two examples because neither of those patients required treatment when they became lymphoma. It was, you could observe them. They were not sick. This patient's sick. So why do we use bendamustine and rituximab instead of CHOP, and why does the patient need to be treated? Here you go. What's that? Algorithm, yes, sir. All right. So when you get to the first line therapy, immunotherapy, that's what you get, right? All
Right.
Now, your patient, you got young patients over here and elderly patients over there. You got the high risk patient like this woman losing weight. You got the low risk patient who's got much wrong with them. And as you go working your way through this, the elderly patient, they try to protect from having to take too strong a treatment. And follicular lymphoma can be treated, if you go all the way down to the bottom, pull that down, you don't need to follow it too much farther, can be treated with a single drug, bendamustine, which is new, and the immunotherapy, which your mother got, rituximab. BKP's mother had diffuse large B-cell lymphoma. This is B-cell lymphoma, but it's not the same, it's not exactly the same.
All right, so let me ask you this, because it was always referred to as double hit.
Yes,
Double hit lymphoma is what.
that's even worse than
Right,
diffuse
so
large
when my
B-cell
mom
lymphoma.
was diagnosed and the doctor came back, there's lymphoma, and by no means with the two of you here would I make light of that. But then we were told it was double hit, and
Okay.
that changed things.
Now, what did double hit mean? Do you remember?
I
There
don't
were
clearly
two
remember.
genetic
Right,
changes, mutations. This patient has 0.
right.
Diffuse large B-cell lymphoma, most of them, 80%, don't have any. Some percent will have one, and 5% or 10% will have two. So that makes it, your mother was in the peak of the mountain in terms of aggressiveness of the disease. And she was over 70, wasn't she?
Yes. And I thank God it's been 3 years and she's
It's a
probably
miracle.
watching right now.
It's a miracle.
Yeah,
All right.
absolutely.
Got it? So anyway, the reason that she's not being treated with CHOP is that it's a different cell type.
She's still alive today to tell me I need a haircut and lose
You
weight.
do not need a
But
haircut.
she's going to tell me I need to lose weight.
Okay, you're not.
You stay over there. I see you grinning, wanting to say something.
Remember, well, we're gonna
Mom's the word. Mom's the word.
We're gonna fix you up with our beauty parlor lady if you're willing to pay the freight. I know it's cost you $8 at the place in Walmart, but we can send you to.
I'm an $8
They can
cut.
scalp you on the top here if you want.
I'm an $8 cut. Go ahead. That's pretty good.
Yeah, I don't know. All right. So listen, the second question we got today is an extremely common condition. This is an uncommon length and presentation and course of it. So a lot of what we're going to be talking about will be raised sort of primary care business, but this case is a testimony to advancing knowledge over time. And it's another thing. It's also about families and how people are trying to manipulate the behavior of their grown children, which Ray and I both have the greatest degree of sympathy for, because nothing I tell my children has any impact whatsoever.
Good luck with that.
I said, good luck with that. My daughter is about to marry a man that is 40 years old. Now that tells me that her daughter is grown up and at least probably in her mid to late 20s or older, and is not a teenager. Would you agree with that?
Oh, yeah, I hope so.
Okay, that's what I meant about trying to tell the kids what to do. But I'll keep going farther. Anyway, a man that is 40 years old and has had low blood platelets since he was 11 years old. Did you get that?
Mm-hmm.
That's basically 30 years of low platelets. He was treated almost continuously since 11 years old and has responded to and failed steroids, intravenous immunoglobulin, Winro, which is a globulin that's against a blood type, Cytoxan, which is chemotherapy, and splenectomy. So you can see all these dominoes falling over a period of 31 years, and his spleen was removed. Now, my next question would be, well, if the spleen came out, that's pretty good treatment for most people. Some will relapse, going on to the next part. After the spleen was removed, he was free of problems for 8 years. Well, that's sort of what you expect from splenectomy, but frequently you do not get cure, and it can recur, and it took his 8 years. He recently relapsed, and he is now on a pill, Promacta, and has normal platelets. Okay, so now he's lived long enough for this new drug, which is equivalent to, remember, Procrit or EPO and Lance Armstrong and the red cells. You remember that, right? Because we all use that. We talk about that all the time. That's a
Right.
drug to raise your red blood cell count when you're getting chemotherapy.
So let me ask this question from a guy just wearing a $12 flannel shirt sitting next to a guy with a $400 shirt.
I think it's a little more than 400.
Okay,
Go ahead.
but anyhow, just the old common guy in the flannel. What did removing the spleen do? That's very serious.
You're gonna get there in the answer in a few minutes.
Okay.
Now, he has normal platelets. He missed 2 weeks of pills. I guarantee you he missed those 2 weeks of pills because they cost about $15,000 a month.
Wow.
And they have to come with from the drug
Wow.
company. and the drug company picks up the charge.
They're not at the local pharmacy.
They're
No,
not
no, well, you
local
also have to
pharmacy.
go rob the bank before you go.
Well, you
pick
really
them up,
don't.
so.
No, you don't, because they're provided to
Let's not
everybody.
rob anything,
So if you've
okay.
got really good,
Let's not-
if you got
put
really
the
good.
disclaimer up.
Now, I'm gonna put, that was a good point. They're $15,000 a month. If you've got insurance, your insurance company is paying $800 a month for them, and you're getting them, okay? The rest of that's crap. Nobody ever pays it at all. If you have no money, you get them absolutely free from the drug company. If-
Unless you're Medicare age,
there you go. And if you're Medicare age,
you're screwed.
well, you're not really screwed, but you're going to be in a donut hole,
Yeah.
and you're going to pay a few $100 a month for it. So the one that has to pay the most for it is the guy who has Medicare, and the regular insurance people and the people that are totally poor, they get it for next to nothing. Okay, let me go ahead here. Oh, and that 2-week period, I guarantee it had to do with the shipping. It went to FedEx, they lost the package, or it went to the post office and they lost the package, because the company sends it out, and don't ask me why, overnight delivery, usually 2 days before you run out. So if there's any glitch in the supply chain, and we know that the supply chain ain't so good, you might not get it for 2 weeks. And I told you the story about mailing the EKG across the parking lot that took 6 weeks to get there. All right.
Post office never loses my mail.
Yeah, right. All right. He missed 2 weeks of pills, and his count fell to 10,000. He's back on the drug, but it took a higher dose to get his count back to 250,000. So when he had stayed off of it and went back to the regular dose, it was partially effective, and he had to raise the dose, which is one of the reasons you don't want to stop these drugs.
Do you really want to answer this last part?
This is what I thought was so funny.
Do you? Go ahead. I'm waiting to hear you.
Are there any issues that my daughter should consider before marrying him? That's why.
Well, my first issue is with mother knowing my boyfriend's health status. That's my. If I'm the daughter, I'm like, Mom, why do you need to know this?
Well, obviously,
There's an old country saying. It's called "I don't have a dog in this." So you go ahead.
I am going to
Tell
say,
Mom, give Mom her answer.
my answer to Mom was, stay out of it.
I don't more, but I say don't go there.
Yeah, and don't try to talk to your daughter about it. But I thought this was a good opportunity.
We do love you. Whoever this viewer is, whoever wrote this question, we're saying that in love. we want all of our viewers.
Yeah, but I guarantee you this is not that viewer in New Zealand that we've got. Because
I put a finer point on it. There's still a possibility that she wants grandchildren out of this relationship, and she's not going to see them if she keeps pursuing this.
Okay, well, and maybe she's worried about the genetics of it.
No, I'm
know.
just talking about the
I
father of the
understand.
children are not going to bring the kids around.
Yeah, all right. That's a good point, Ray. Okay, a lot of this, what we're talking about, is going to be primary care. Put up the first one. You got it up?
I'm just wondering if he knows his entire medical just got sent to us.
I just want to know how she got it. All right.
Sorry, we need to answer this. Sorry,
Okay.
we're out of the way.
Okay, the topic is low platelets. He has immune thrombocytopenia. Pull that down. So I'm going to walk you through pretty quickly what happens. 11-year-old kid, obviously he was bleeding or something. But most of the thrombocytopenia is a patient in Ray's office who's getting a routine physical, and his platelets are low on the blood count. He's not sick.
No symptoms whatsoever.
No sick, and he's not bleeding. So if you look up this, if you get this BKP, I don't want to bore you.
You're not boring me.
Well, I'm getting ready to bore you, because this is 3 whole pages of the causes of thrombocytopenia in adults. You got that? Mm-hmm. All right. Now, the first 5 of them are
Falsely low
falsely
platelets.
low. Okay, most of the patients that Ray sees with low platelets don't have low platelets in their body. They got low platelets in the tube, because you can leave it up there a minute, because those platelets have got an antibody on them and they clump. so that this machine counts them as a single particle that's bigger than normal. It doesn't count the size. And so you can have 300,000 platelets, which is normal, but they clumped up and it says 10,000 on the tube.
It's a machine error or
Machine
a chemistry error. Yeah.
Okay, and that's quite often due to using an EDTA tube, basically the way the anticoagulants work. So all you do is send them to the hematologist, and he uses a blue tube instead of a pink tube, and the platelet count's normal, and his guy puts the pink tube under the microscope and shows his clumps, and we send them back and say, don't worry about it. All right, but then when you get to the ones that are, the next is, the next most common is this disease, idiopathic thrombocytopenia purpura. But look at the second one here. What's that say?
Primary immune.
Right there, little one. Quinine.
Quinine.
Quinine, okay. Over-the-counter tablets for leg cramps.
Right, quinine.
When you
Quinine,
go to the
right.
drugstore.
You can't get them in this country anymore. But
No, but
What?
but
Quinine.
well, you can get it from Canada, and you can get.
Well,
But
okay.
you're true, you can't buy it over the counter. But what can you get it from?
When you say beverages.
tonic water.
Yeah, you get tonic water, right?
Yeah, you get tonic water. All right. So what we gonna-
Because my dad always got, and my mom and them, but my dad more than anybody would get, he liked the cranberry, and he'd get the
switch to the next two.
with the quinine in it.
Yeah, tonic water has quinine.
Okay, well,
Yeah.
we're getting a little, so you can switch it around to the quinine one. Okay, available forms of quinine. Quinine is still used as a anti-malarial. We can prescribe it in this country. People sometimes prescribe it for leg cramps, and you can get it for that purpose by prescription. But the next one is gin and tonic. Bring that down.
Hey, listen, I want to.
Now, he didn't do gin and tonic. He did cranberry juice and quinine
Okay.
tonic.
We're talking about zebras here because while quinine's not available over the counter. It's harder to get. Physicians have to hassle to get it. I've been prescribing quinine for leg cramps my entire career, and I don't think I've ever seen a case of.
Oh, no. But think how many people drink gin and tonic.
Yeah.
Now, so if you got millions drinking gin and tonic, you're going to end up
Yeah,
in a hematologist's
okay.
office with a few. It
Yeah,
doesn't
with a
have to
few.
be- it doesn't
I'm
have to
just
be-
saying it's pretty rare.
Okay, so now go back to that next one. So the common presentation of platelets with thrombocytopenia, so I gave you the causes, is, what's the most common presentation? Asymptomatic, isolated, incidentally discovered, meaning they ain't sick. You got it? Mm-hmm. All right, now we'll get into primary care. Put up the next one. Now, we've seen this before. We were talking about chemotherapy, and we were talking about low platelets. But that pretty picture of that rash on that leg there, a good PCP knows that's not poison ivy, that's not bed bugs.
Those are
that is
petechiae.
Petechiae or bleeding in the skin.
Yeah. You're in trouble there.
You're in trouble there. Now, I'm going to go into the next one here before I get into these algorithms, and we're going to turn this one over to Ray. What's that say?
Investigation of vaccine associated.
Okay. When I get into this causation I just got through showing you, there was no category that said post-vaccine. Now, there have been one vaccine prior to today in the past that very rarely, but often enough to be known, was associated with dropping your platelet count. Now, I'll be quiet and let Ray have the floor.
Well, one of the things that's happening as we are getting into the weeds with the current COVID vaccines is that there are cases, they're relatively rare, but they're catastrophic, of people having thrombosis, DVTs, platelets, where the platelets aggregate and cause these clots. We don't fully understand it. It is rapidly being investigated, but it is occurring. And the science is unknown on this, but it is one of those risk factors that we as physicians were not told, that was not properly studied because the vaccine didn't go through proper studies, and it's now a big issue.
Now, you have to get, now I'm not Fauci, but I'm going to give you the other side here. COVID caused people to have dramatic clotting, and that thing was killing a third of them in the early parts of the epidemic. They learned that as soon as you hit the hospital with COVID, you start anticoagulating them, and then that group of people didn't die. So the disease caused this about 1/3 of the time when people were sick enough to get in the ICU, and killed them. So it's something about about that. And
Spike protein or
I don't
something.
know. It's way past me.
Well, it's not past
Anyway.
us, it's just we don't know yet.
We don't know. Okay, let's go to the next one. So now you've got. This is how you're going to handle this. All right. First, get up the next one. This is a algorithm. All right. This one is approach to increasing the platelet count in ITP. Well, number one, do you have to increase it at all? I'm going to come to that in just a minute. So if you do not have bleeding, all right, you got bleeding over here. If you have no bleeding and your platelet count is 30,000 or more, you do not treat this disease. So it's like the abnormal lymphocyte count in early leukemia, you watch it. It's like follicular lymphoma. When you're not sick, you watch it. But 30,000 platelets is enough to get through life and have. One thing I always say about immune thrombocytopenia is you're making enough platelets. They're getting covered with an antibody and getting sucked up by the spleen. So every one of these 30,000 platelets is like a 19-year-old Marine right out of boot camp and not an old man. And the next thing I tell people is well, I don't understand that. I say, I just want you to imagine you got a handful of marbles and you roll the marbles across this carpet. How far are they going to roll? Now, you're going to cover those marbles with honey and roll them again. How far are they going to go? They ain't going to go very far. So that spleen is like a shag carpet, and the platelet is like it's got pancake batter or honey on it, and it's going to stop in the shag carpet before the other one does. So that's basically the physiology of thrombocytopenia. So once they get to the point where they've got critical, like bleeding in the brain or something, you got to give them platelets. If they got bleeding from their gums and somewhere else, what do you do next? All right, next algorithm. You got it? So, if you have bleeding, not catastrophic, then you immediately have to do something. And then the standards. She said this guy had glucocorticoids or steroids. He'd had IVIG. They never said that he required any platelet transfusions. Okay, pull that down. Now, you want speed in response to the treatment. So, in some places you want speed in response to the treatment. The pathological bleeding, you got to give them platelets. Immediately simultaneous with them, you give them the steroids so that hopefully those platelets don't get sucked up like the other platelets did. And you give them intravenous gaiboglobulin, which would bind up the antibody that's wrapping that thing up. And then you get the patient through this acute episode in 24, 48 hours. Now then when you start talking about giving steroids, it takes 48 hours to 14 days to work. IVIG takes 1 day to 3 days. And so it's all of these things. And when you take the spleen out, it can work in an hour. But the spleen is not where you start in treatment. Put up that next timeline. All right. This boy has had this disease 30 years. And so if you look at this timeline, it doesn't give you years, but just thinking of 30 years and listening to the story, he went through all of these things, and 8 years ago, so that's about 2/3 or so of the way down the 30 years, right? They took out his spleen. So he got the treatment on terms of the timeline pretty much exactly like you would want to get it. Pull that one down. Now, Ray and I were talking out here a few minutes ago that one of the other common reasons that you see low platelets is because the patient in your office has been having 2 cocktails at bedtime or in the afternoon for the last 40 years. He's not an alcoholic. He doesn't have any kind of substance abuse problem, or he's overweight may be diabetic or hypercholesterolemic, never had a drop of alcohol in his life, and has what we call fatty liver. Well, 40 years of 2 drinks a day, or 40 years of overweight, elevated cholesterol, and fatty liver, that liver will become scarred. That's non-alcoholic cirrhosis or alcoholic cirrhosis. The spleen begins to get bigger. Now you ask the question, why do we do this splenectomy? So here's your answer, BKP. When you have a normal spleen, then the lifespan, way over here on the left, and of a platelet is normal. When you have a little bit of splenic enlargement, it gets into the 50,000 range that you can observe and not do anything with. And if your spleen's got some size to it, you get down here where your platelet count can be below 30,000, and you don't have any kind of bone marrow disease. You don't have any kind of, you pull that down now. You don't have any kind of antibodies on your platelets. You have just got a spleen that's a little bit large. Pull out the next one here. So now we're going to, how about that big old thing there? Up until about the last, I'd say, 10 years, goes back at least 20 or more, splenectomies were done by open surgery. I recall, see that big old thing? That's big as that's
like
as big as a half a loaf of bread there, isn't it? Pull that down. I can remember back in 1956, I still see this patient. She was an 8-year-old girl. She had 0 platelets. Responding to IV platelets and steroids, we did not have IVIG in those days. She was continuing to bleed, and Bill Reed, who was the best surgeon in Atlanta, fast as lightning, was going to take out her spleen one morning at 7 o'clock in the morning. And I just had promised that little girl I'd be there. So I got to the operating room, and I scrubbed my hands and got off my mask and everything. And I watched Dr. Reed walk in from scrubbing his hands, and the length of time that Ray got here before we sat down is longer than it took me to walk in there. And I walked in there and I said, how you doing? He says, here it is. And he dropped the spleen out there, and he had removed that spleen in about 3 minutes. Now that's a World War II combat surgeon. And he got that spleen out really, really quick. So I was impressed, and her platelet count was about 300,000 an hour after the surgery had been done. She's done fine, and I continue to see her as an internal medicine patient in Atlanta. Put the next one up. I have been very impressed at how good our people are with the laparoscopic splenectomy, which is done through a series of sticks in the abdomen like a tubal ligation or something. You can pull that down. But I've seen spleens that were this big removed by the laparoscope. Now, how do you get out something that's that big when all you've got are puncture holes that are about that big? Answer to that question is they go somewhere in the abdomen, and they make a little incision about this big, and when they go in there, they chop it up in little pieces. And they go in immediately, and they clamp the artery and the vein so there's no blood coming into it. So when you're chopping up the little pieces, it's just like you had that spleen out in front of you and you're chopping up the little pieces. But that's way past what Ray and I do. We're very impressed with the guys that do it. But that operation can be done here in the mountains by some of our local surgeons who are very adept at that surgery. So now to answer the question, this patient is doing well on these new drugs. He's going to have problems for the rest of his life. We don't know, but there are patients on these new drugs who are years out. And I would tell the mother to stay out of it, let the daughter marry the guy. And this is not a genetic disorder. The kids aren't going to have it.
So the new medicine is basically stimulating the bone marrow to make more platelets.
It's procrit for platelets.
For platelets.
Procrit for platelets, yeah.
And people, we're talking about low platelets here.
Really low platelets.
really low platelets here, but, people are much more knowledgeable about treating platelets after heart caths and stents, where you're giving Plavix and aspirin and other medicines to try to make the platelets less sticky and less likely to clot and cause problems where you've been in the heart. So platelets are on both spectrums. You're either trying to dull them or make them less sticky, or you're trying to make more of them and make them more available to the body.
Thank you, Georgia Cancer Specialist, Northside Hospital Cancer Institute, for our questions this morning. So, you have any news of the week?
Yep.
Anything? 'Cause I have a question.
I was getting ready to. This is a Ray Tidman question. What's a artificial intelligence?
Oh, okay, all right,
Yeah.
all right.
And
In healthcare, artificial intelligence in healthcare.
No,
No,
the robots are not taking over. Okay, we discussed the fact a few weeks ago. Siri is artificial intelligence. That they were using an artificial intelligence algorithm to
Right.
try and predict who was going to get Alzheimer's disease. I think that was in England. But the point is that, and I've mentioned this, I think, last week when Ray wasn't here, that doctors today don't do physical exams much. They rely on tests.
We
Remember
talked-
that?
yes, we
talked
did.
about that, and they
We
don't
talked about
feel for the
physical
spleen and
exams.
stuff.
right.
Okay. There's a little wave coming back this way, that thinking about the patient, examining the patient, and analyzing the data yourself is important in outcomes, and that's what this was about.
All right, here's my question.
Yes.
Yeah.
Well, obviously, the media has to run their fear factor
Right,
and see if they could put all the parents in panic.
right.
So we have a tripledemic now, according to all the big flashing lights they put up on the high definition TVs, that we're all in a tripledemic. Why the flu, RSV, and COVID, and the fear, I mean, it's daily we have to have these fears. I mean, I guess, what's going on? I mean, RSV.
Well, I think you nailed it. I think what's going on is that they want people to be afraid and they want their eyeballs glued to the tube, but there's really nothing going on. We have a bit heavier of a flu season.
Well, the RSV for kids is real.
For RSV for kids is up, but it goes up. We have flu seasons that go up and then they come down. This is nothing to panic about.
Well,
There's
no, wait a minute.
no reason to shut the country down.
Oh, no, you don't shut the country down. But the RSV epidemic is one of the bad outcomes of having been locked down.
Yeah,
Because normal
Yes.
children begin being exposed to other normal children when they're 3 months old and they go to church and they're in the nursery.
yeah.
And then when they're a
Thank
year
you.
old, they have play dates and they play in the mud. And then by 3 years old, there's some of them are going to preschool. All right, well, let's just say this is 2.5 years long. That exposure for that 30 months did not occur.
That's a very important point, and I tell my
That's
mothers,
the RSV, because
plus all the other little viruses that
they would have had all the other little viruses. So now they're going back to church, they're going back to school, and they're getting RSV for the first time, and it's real.
And I tell my parents, your child's immune system is going to college. And that's what they're doing in the first 2 or 3 or 4 years of life, is they're running around with a little booger nose on the rug and, sharing
Remember
toys
now,
and
they're
licking.
supposed to eat a peck of dirt before they're whatever
Yeah.
that statement was, but they're not. That is where the RSV is coming from. So that's true. That's kids.
Yeah.
Now the double epidemic in our age group. Wait a minute. Now I got to get my thing here. How many cases of COVID were there in Fannin County last week?
6,
No, we got. How many of them died?
0.
How many have died? Documented died in the last 6 weeks up here.
0.
That number we've had every week for weeks and weeks and weeks. So yes, COVID's out there. I've got 2 employees out right now. My nurse practitioner in Atlanta's out. She ain't the least bit sick. She was exposed. They made her get a test because she was exposed. She was positive, so she now gets a 5-day paid vacation because she's got the COVID. So it's out there, but it ain't making people all that sick. And yes, this flu season has begun to happen. We didn't have much of a flu season the last couple of years. People weren't getting together. You get the flu in the elevator, right? Well, now they're in the elevator, so they're going to get a common cold and the flu.
Has the increase in using hand sanitizer,
Not a thing. COVID is not spread by touch.
well, has it reduced our,
So that's the old question about over cleaning. I think I think that the science is pretty good. Our bodies are, let me just go back to this basic number. Our bodies are covered with 35 trillion microbes. That's our normal state.
Bacteria.
Okay? Bacteria, funguses, viruses. Okay, 35 trillion. Get your head around that number. You cannot clean all those off.
By the way,
cannot
that's
sterilize
what the
those.
national debt is now.
Oh.
Okay,
Maybe we can have the microbes pay off the debt.
one more quick question, because I gotta get out, I have to
Yeah.
be somewhere, I gotta get out, he's gotta go to work.
And I have an important observation, but go ahead.
Yeah, we never know where
He's
you're
going to the
going.
dentist.
Okay, so what's with the shortage of medications that they're, again, on the high-definition TV that we, what's up with that?
I'm clueless about that. I mean, these are some good medicines, new medicines, and there's a medicine for diabetes called Ozempic. We're constantly trying to find it. I have no idea what's going on with that industry. They shouldn't be running out of stuff.
I still think it has to do with post office losing everything.
Yeah, it could be. No, they never do that.
So you have a final,
Well, I don't know are there any Irishmen in this room here?
Yeah, I'm Irish.
So, you know what the last thing an Irishman with Alzheimer's forgets? A grudge. One of my Irish patients told me that, so I'm good. There are a lot of Scotch-Irish in the mountains here, so.
all right, anything with you? You good?
I'm good.
You gotta get to work?
I got to get to work.
Look, if we,
Ray's going to the dentist.
Yeah.
if we go now, you could be on time,
All
and
right.
they don't blame it on me.
Thank you.
Thank you, Georgia Cancer Specialist affiliated with Northside Hospital Cancer Institute. We appreciate you very much. Again, we don't know where he's going to work. We never know
He's
where
going
he's
to the
going.
dentist in his
And
$450
We
shirt.
have
Yeah.
a surprise for you on the other side with the All-Star Political Panel. Take a break.